it's important that we catch ourselves with those little orders of words that we use, and I'm glad that you did it because it was quite a humorous point, but it's also an important thing to remember that there's nothing that occurs in society that occurs in terms of our interactions with each other that occurs naturally. Everything is engineered by external forces, which is what makes it so interesting when you hear people like Mark Latham. Mark Latham talking about how these bloody social justice warrior lefties are just trying to socially engineer everything, as if somehow certainly the past 200 years in Australia has not been a result of chronic social engineering. And that's partly why I brought my baby with me today, because I wouldn't normally choose to do it because he's such a crawler now. But there was nothing that could be done. And when I arrived, I said, I'm sorry, I had to bring my baby. And Lynette, I think it was, said, don't apologise, don't say sorry. And of course, we also have to start doing that if we have children, particularly if we're women with children, because so much of the burden of domestic labour falls to us, and we know that it's unpaid and it's largely unappreciated. And for the joy of being a mother, we can also enjoy the joy of being disparaged and disregarded in the wider community, because mothers, blech. So one of the ways that I've been challenging myself to challenge the structures around us as well is when I do have to bring my baby to something like this, or even if I have to put him down in the library and find someone to watch him while I go to the bathroom. I know that some people do not feel comfortable with leaving their children in the care of strangers, even just for 5 minutes. And that's fine. I mean, people have their reasons for not feeling comfortable about things. But I'm trying to model a community attitude where we can trust people to raise our children, or at least assist in the raising of those children. Because otherwise, the idea of the four-walled parenting model that, again, largely falls to women to be the coordinators of, will persist, and we won't actually be liberated from those roles. So one of the ways that I'm trying to challenge that to happen is to ask men to participate in that care. Again, it's something that makes some people uncomfortable, it's an unfortunate reflection on some things that happen in society, and it's an unfortunate thing for men too, because I think that men would gain a lot from being asked to participate more in the care of other people's children. So Jack is downstairs right now taking care of my baby. Because I want, in the challenging of ideas, I want people to challenge the idea that work will just happily fall to a woman who's present, because of course women all love babies and they all would love to take care of someone else's baby, particularly if they have babies of their own. There's nothing more than they'd love to do than take care of someone else's children. But this way I invite men to participate in that workload, and I also model to my son that this is not just the work of women, and this is not just the labour that will be performed for him by women. So that's just some of the little things that I'm thinking about. It's not what I'm going to talk about today. I thought that it would be appropriate for me to discuss, I'm just going to take this jumper off, it's very warm up here. I thought it would be appropriate for me to discuss something to do with reproductive healthcare, actually, given the nature of the conference. And I thank all of you for the work that you do, particularly, obviously, as you work in rural communities. But I recently spoke to medical students at the University of Melbourne, and I wanted to discuss 4 elements of reproductive healthcare for women, particularly in regards to pregnancy, carrying through with a pregnancy, postpartum health, and preventing a pregnancy. And it was really encouraging at the end how much they embraced the content of that talk. And it was also interesting to see how little they had heard about it in their studies, some of these things. I mean, I think that when we talk about reproductive healthcare, and when we talk about reproductive healthcare in terms of actually carrying through a pregnancy, everyone's an expert, but of course that's not true. So one of the things, I guess I'll just go according to the amount of time that I have, but one of the things that I've obviously been very passionate about in my career is the topic of abortion and access to abortion, and access to abortion as a fundamental right and a fundamental tenet of reproductive healthcare. I'm not sure what battles you face in rural communities in terms of overcoming stereotypes about abortion or access to abortion, but of course I know that the reality for a lot of women and people who need to seek abortions if they live in rural communities is that it's much more difficult than if you live in cities. And not just in terms of physical access, but in terms of overcoming perhaps some community stereotypes and perhaps even in the dynamic of the relationships that they might be in. And one of the ways that I think that we can target this and we can change this is to become a lot more transparent and a lot more honest about what abortion actually is and what abortion presents as an opportunity for the mostly women who will find themselves having to deal with those questions. And when I say mostly women, I'm acknowledging the fact that not all people who, in the enormous gift that has been given to us from the LGBTQI community in terms of understanding the breadth of gender, not all people who can get pregnant will identify as a woman, and they may identify as a trans man or they may identify as a gender diverse or gender non-conforming person. Largely, though, the role of reproductive labour is still falls to cisgender women and is still an expectation of them in terms of reinforcing that gender binary and reinforcing ideas of gender labour. So just legally, I think we'd all be familiar with the fact that Victoria has only officially removed abortion from the Crimes Act in the last decade. Prior to 1969, it was illegal to either seek or provide an abortion, and we know that, and I would hope that everyone in this room understands that removing access to safe and legal abortion doesn't stop abortions from happening. It only impacts the means by which those abortions will happen. I was really surprised to learn in some of my research that in the 1930s there were so many women presenting to the Royal Melbourne Hospital with septicemia from unsafe abortions, and most of them self-inflicted, that a separate ward was built to contain not only their numbers, but also to contain the stench of the gangrene that they brought with them. Between 1930 and 1933, over 1,000 women died as a result of those post-abortion infections. And women continued to die for the next 40 years, up until the Menhennet ruling of 1969. Is everyone familiar with the Menhennet ruling? I don't need to cover that for anyone. Okay, so in 1969, a test case was put before the Victorian courts to find a loophole in what I would say are the dangerous, archaic laws around reproductive health and around abortion access. The finding of Justice Menhennet. Essentially what happened was a lawyer, and they needed to find a lawyer and a doctor willing to do this. They needed to find a doctor willing to say that he would perform an abortion on a woman if her health was directly affected and if her life was at threat. So they managed to find that, and they put this case as a test case before Justice Menhennet, and he ruled that although abortion would still be considered a crime, it would be acceptable in cases where the life of the mother was at threat. So it changed the nature of how you could access abortions in Victoria. Although it still kept it in the Crimes Act, which meant that even though you could technically secure one, you were still technically considered to be committing a crime, which is what changed in the last decade. And not coincidentally, so that happened in 1969, and not coincidentally, the last woman to die in Victoria from post-abortion complications died in 1970. So why do I think abortion law and advocacy is so vital to the health profession and to healthcare professionals to push for it, and the women who will invariably be represented by it? I'm aware that there may be a degree of different opinions on abortion in this room, and that not everyone will feel like it's something that they support, not everyone will feel like it's something that they could have themselves. But I think if you apply logic to the situation, then one fact remains indisputable, and that's that as long as women are called on to perform the bulk of reproductive labour and child rearing, there's going to be demand for services that enable the termination of pregnancies. A recent study outlined the prevalence and rates of abortion worldwide in countries and regions where it's both legally accessible and legally denied. And the study was published in the Lancet Journal, and according to the Washington Post, it represented the most comprehensive analysis ever conducted on the subject of how abortion rates differ between regions separated by wealth and development. It was lead authored by Gilda Said, and she was the principal research scientist with New York's Guttmacher Institute. The study found that an average of 56 million abortions took place annually from 2010 to 2014, which equates to roughly 35 procedures per 1,000 women of childbearing age. But the authors noted that in countries where abortion is illegal or permitted only to save the life of the pregnant person, the rates hovered at around 37 procedures per 1,000. And even though that was essentially no different from the rates found in the 63 countries where abortion was legal, or that may have changed now, that number, in this grouping, abortion is accessed at a rate of 34 pregnancies per 1,000. So the authors strongly concluded from this that restrictive abortion laws do not limit the number of abortions. And I just want to paraphrase Dr. Jo Wayner here, who wrote in her collection Lost Illegal Abortion Stories, the law has never been able to prevent abortions. All it has ever succeeded in doing is changing the manner and safety with which women access those abortions. If you force desperate women into even more desperate measures, all you'll achieve is an increase in the likelihood of those women dying. So the best way, I think, to lower abortion rates is to provide early contraceptive intervention options to women. As reproductive healthcare workers, you can attest to the fact that abortion rates remain steady in places where access to adequate contraceptive methods is limited or even illegal. But which is to say that when you limit the access to abortion, when you limit access to early contraceptive methods, then abortion still retains at the same rate. One of the quickest and easiest ways to ensure longevity for infant and maternal health, in particular, is to give women comprehensive options to control the size of their families. The use and appropriate education of contraception in the so-called developed world is almost certainly more responsible for declining abortion rates than the antiquated rhetoric about morality that spews forth from people whose concern for life and vitality ends the moment a baby emerges from the womb. But there are still too many individuals and organisations around the world who remain determined to prevent women from not only accessing terminations, but also from being able to prevent conception in the first place. Donald Trump. I shouldn't have said his name. I just feel so rageful when I think of him. Did you hear that he fired Anthony Scaramucci? Yeah, I saw a great tweet about it. Hands up if you've had a period that lasted longer than Anthony Scaramucci's career. And another tweet that has basically said that same thing and said, oh, hang on, wait a minute, sorry. So you see, White House, a woman's menstrual cycle is this thing. But these findings have particular resonance for us in Australia, where reproductive healthcare law varies from state to state, and it's especially pertinent to arguments pushing to remove abortion from the Crimes Act in both Queensland and New South Wales. We know that the reason that women die from abortions isn't because abortion is unsafe, performed in a sanitary environment by a trained professional, and in a state in which access to appropriate mental health care is also provided, and support for the woman involved is absolutely vital, then abortions become uncomplicated medical procedures largely that more frequently than not improve the physical and mental health of those seeking them. Abortion in these circumstances is in fact less dangerous to a woman's health than pregnancy and childbirth, and has a far lower mortality rate. One of the things that I think that we need to start doing, which is quite a controversial and challenging prospect, and I understand why it is, because in terms of a termination, it's easier to talk about using a birth control pill to prevent implantation, if people even understand. Obviously this room does, but the fact that we have lawmakers who don't understand how the birth control pill works is concerning. But it's easy to talk about preventative methods to prevent pregnancy and to separate pregnancy termination from the banner and the umbrella of contraceptions and contraceptive methods, because so much of the rhetoric from the anti-choice movement has always focused on the fact that women, of course, sluttish, skanky, all the words that you can possibly use about women. I mean, I wrote about 2 abortions that I had, and the comments section was just filled with people who said, well, you're a slut who should have learned how to keep your legs closed. I mean, it's fine, like, none of this bothers me, but of course, no one mentioned the man involved. There was an assumption that I was just standing on a street corner, just bent over, and everyone could just have a go, because how else could you possibly get pregnant twice? That these kinds of women are so full of disregard for morality and for their bodies that, of course, we use abortion as a contraceptive method. I mean, even if you leave out for a moment the fact that of the hundreds of times that you might have sex in a 10-year period, or even the dozens of times, I mean, sex rates are on the decrease, let's be honest. We've all got phones now. To get pregnant twice is not exactly implying that you're out there on the street corner bent over for everyone to have a go. But any woman who lets herself get pregnant, lets someone impregnate her, and then dares to get rid of it is, of course, someone who we must heap shame on. And the assumption is that we're all just using abortion as a contraceptive method. And in response, the pro-choice movement has always reiterated that this is not the case. And of course, it's true. Women don't use abortion as their first go-to contraceptive method. It's not easy to access abortion. It's not easy to undergo an abortion. It's not fun to go through an abortion. And it's definitely not fun to stay pregnant in the days that you have to wait for an abortion. So it's not something that anyone would logically or reasonably do as a form of contraception. But that doesn't mean that it's not a form of contraception. And that's where I think it's important to start reframing the way that we have these discussions. Because when you think of pregnancy termination as one of the tools, perhaps the end tool, perhaps the tool that you don't want to use, but still one of the tools that you have to be able to maintain and assert autonomy over your own body and autonomy over your own reproductive self-determination, then it's difficult to maintain the idea that it's somehow a shameful thing to do. If you accept as a community of people, and not everyone will accept it, of course, but if you accept that its purpose of ending a pregnancy and of reasserting self-determination over someone's life when they're not ready to have a child, that puts it in the back bracket of being a form of contraception. And I think that we would actually, if we started to have that conversation, actually have a lot of really important progress eventually in terms of how we talk about abortion, how we talk about women's bodies, how we talk about pregnancy, and how we talk about people's rights in terms of accessing those pregnancies, accessing those abortions. There's a lot of misinformation, as we'd all know. There's a lot of stereotypes, and there's a lot of morality and shaming around this topic. But fundamentally, it's no different to any other medical procedure, and the discussion of it really is only the business of the person seeking the procedure and the healthcare provider in providing that procedure. And even then, their business is only to provide a quality of care and a quality of service. So I'd be interested to know what you think as healthcare providers, and particularly as rural sexual healthcare providers, in how that could be achieved, or whether or not that's a bit of a pipe dream. But I think when you have open and frank discussions with people about not just the consequence of pregnancy, but the consequences of childbirth, and the consequences of pregnancy and childbirth in regions and areas where access to healthcare is further and further diminished, particularly as poverty increases and social mores increase in one particular way. If people are willing to have that conversation, then they couldn't possibly maintain the idea that somehow the best punishment for a woman who's allowed herself to get pregnant, when they are holding also that woman is not responsible enough to have a baby, is for her to be forced to become a parent. And of course, then there's the breaking down of stereotypes around who it is that accesses an abortion. People like to think that it is the woman who has no moral code, who sleeps with everyone that she sees, who of course exchanges sex to get love because she has got such terrible, crushingly low self-esteem. And yes, of course, the best thing to do then would also be force her to become a parent. But the reality is that the makeup of people who access abortions is incredibly diverse. Yes, you do have teenagers who access abortions, but they're far more likely to hide pregnancies in an environment where they're made to feel ashamed and terrified of what the consequences of that pregnancy might be. And we also know that most women who have an abortion, who don't have children, will go on to have children at some point in the future, or already have children already. So I think in terms of humanising the discussion and the dialogue around reproductive healthcare in terms of pregnancies and terminations, it's important to start stripping away some of the more moralistic ideas that people have, even on both sides, and that if you are a pro-choice person and if you're a pro-choice healthcare provider and you want to break down ideas and stereotypes in your communities, then it's necessary to stop fighting those battles using the language of the anti-choice movement. So not talking about things like women don't use it as a form of contraception. Because as I said, the reality is that women don't use it as their first point of call as contraception, but women who find that all other points of call in terms of using contraception have failed do use abortion to end pregnancies, and that is a contraceptive method, and that is a contraceptive method that is their right in Victoria to do, that should not be subjected to any other to any further queries or scrutiny, particularly not from members of the public, than any other medical procedure would do, and that if we're going to think about all of the multiple children that the anti-choice movement likes to sort of wave around. I mean, I'm always told, like, think of your 2 beautiful babies that you would have. Then we also need to sort of start responding with actual logical outlines about what that looks like. That if we live under the parameters of cause and effect, which of course we do, then one choice changes the outcome of another choice that we might make later on. Which is to say that as someone who's had 2 abortions, I could never have had those 2 babies simultaneously, because had I had the first baby, the second baby would never have happened. I could only have ever created the second baby if the first baby hadn't been brought to term. But the reality is for many women like me who have children now who've had abortions in the past, the children that we currently have, the children that we had the autonomy and the self-determination and the resources to be able to bring into this world and to care for, they would not exist if we were forced to make choices earlier on, or forced into choices earlier on that were not what we wanted. And it's interesting to me that there is actually a whole generation, the generations and generations of people who exist in the world and who contribute positively to the world, whose lives would not have existed had women not been supported to make choices about their own reproductive health care. So I feel like these are the things that I want to bring to discussions around terminations. I had in this discussion that I'd had with students at Melbourne University been able to also discuss, it was a much longer talk, but I'd also been able to talk about the reality of postpartum healthcare and why it's so essential that you also give women control over the pregnancies that they do bring to term, because the impact and the damage that can be done to women's bodies postpartum is something that firstly should not be ignored, but is too widely ignored. It astonished me after I had a baby to realise that pelvic healthcare is a very real thing that needs to be expressed beyond just your healthcare provider saying, now make sure you do your pelvic floor exercises. It was not adequately explained to me, and thankfully I haven't experienced pelvic organ prolapse yet, because we of course know that the risks are ongoing. But it wasn't adequately explained to me that this was a very real risk for women who particularly gave birth vaginally. It wasn't explained to me that there is no real appropriate treatment for this besides exercise, and that for women who suffer pelvic floor muscle tears, the outlook is fairly grim in terms of rehabilitation. This seems to me to fit into the larger umbrella of how the healthcare of women and the sexual healthcare of women, and the sexual healthcare particularly of women who have uterine reproductive organs, is minimised and diminished and considered as somehow separate to the real healthcare that occurs. Now, I'm just saying that as someone who exists outside of the system and as someone who occasionally requires care from the system. But that's the way that it feels to me, and I'd be interested again to know what you think as healthcare providers. I think I've got a couple of minutes left now where we could have a couple of questions. I hope that has provided some food for thought for some people, and that it's going to stimulate some interesting conversations. I hope more than anything that I haven't just stood up here and tried to teach you how to suck eggs.